Welcome back to our video series. I'm glad you decided to check in, and we hope you find this information helpful. My name is Jen Ivanovich, and I'm the director of the Young Women's Breast Cancer Program. With funding from the CDC and support from the Siteman Cancer Center, we're able to bring this video series to you. I also work as a clinical cancer genetic counselor at Washington University School of Medicine in St. Louis. I have the privilege to work with families who have cancer. Today we're going to talk about genetic testing. And specifically we're going to talk about what is genetic testing and why is it performed, the best approach to genetic testing for people who have a diagnosis of cancer, what we can learn and not learn from genetic testing, and a few comments about genome sequencing. Let's first start with defining what is genetic testing. A sample of blood or other tissue specimen is obtained, and analysis of specific genes is performed. Laboratories use different techniques to look at the gene sequence and the structure of the gene. The intention is to identify if an abnormal gene change, or what we refer to as a gene mutation, exists. Since we share genes in common with family members, gene mutations may also be shared among family members and passed on to our children. Knowing if these gene mutations exist allow us to guide a family's medical care. Genetic testing has been performed for decades. Some people pursue genetic testing prior to conceiving a child. That couple wishes to determine if they're a carrier for a specific disease that their child may inherit. Sometimes we perform genetic testing on children who have health problems at birth or problems that are identified soon after. And we're working to identify why that child has those specific concerns. And some people pursue genetic testing simply because they're curious. They want to understand more about their family ancestry. Genetic testing is performed more often for people with cancer. There are two basic types of genetic testing that we use for people with cancer. The first is genetic analysis performed on a tumor. Different laboratories use different names for the techniques that they perform. But in general, they're trying to identify or better characterize some of the genetic makeup of that specific tumor. And we use that information for therapeutic purposes, to identify therapies to target that specific person's tumor. That's not the type of genetic testing we're going to focus on today. Rather, the genetic testing we're going to talk about is that testing that is performed for families trying to identify if they have hereditary cancer. Most people with cancer don't need to have genetic testing. We reserve that testing for people who have a personal history and or a family history that suggests that they might have hereditary cancer or cancer running in the family. We look at the family history and the person's personal history to make that determination. And we've talked about some of those features of the family cancer history in a different video in this series. It's an important point to consider that we only reserve genetic testing for those in which we're concerned about the possibility of hereditary cancer. We use that information in our interpretation of the results, and more importantly, the screening recommendations that we make for family members based on the results of the testing. We start by evaluating the person's personal cancer history as well as their family history. Some people ask me about genetic testing and don't see a need to complete their family cancer history, but we use the combination of this information to first address the question, does this family appear to have hereditary cancer? And if so, what genes might we consider for testing? Let's consider the best approach to genetic testing. Now remember that your medical team has raised the question, does your family have an inherited condition? In this case, does your family have hereditary cancer or cancer running in the family? So the best approach to genetic testing is to test an affected family member first, someone in the family who has a cancer diagnosis. In essence, what you're saying is, we are concerned about an inherited condition and that condition happens to be an increased cancer risk. So let's test someone in the family who we assume has that family gene mutation. We make that assumption because they have the cancer diagnosis. So always start genetic testing with an affected family member first. Sometimes that's not possible. The family member who's been diagnosed with cancer may not be interested in genetic testing. Or perhaps the family members have passed away and there wasn't an opportunity to offer them genetic testing. But whenever possible, start genetic testing with an affected family member first. And if a gene mutation is identified, then we have new information to guide that family's medical care. Now let's consider what we can learn and not learn from genetic testing. And we're going to use two different family examples. Let's consider family one. Jeannie is a 42-year-old woman who's been diagnosed with breast cancer at 38 years of age. And you'll see in the slide that we use a pedigree format to document her family cancer history. We've talked about the pedigree format in a different video, focused on the family cancer history. But just as a review, we use circles to designate females and squares to designate males in the family. Jeannie has a sister and brother. Jeannie also has a 22-year-old daughter. We see that her mother is living and is healthy at 75 years of age, and there's no cancer on her mother's side of the family. However, there's a very different story on her father's side. There's a very striking family history of cancer on her father's side of the family. We know by evaluation of the family history that this family has hereditary cancer. They have all of the features that are diagnostic for hereditary cancer, including multiple generations, multiple closely related affected individuals. We see individuals who were diagnosed at a young age. It's a combination of these features which show us that this family has hereditary cancer. We know this based upon the family history. We haven't performed genetic testing yet, but based on the family history, it's clear this family has hereditary cancer. Now let's say Jeannie comes to see us for genetic counseling, and she's interested in learning why her family has the cancer in the family. Based upon her family history of early onset breast cancer, ovarian cancer, as well as the history of prostate cancer for her father and pancreatic cancer for her paternal grandfather, we recognize that this family could have a mutation in either the BRCA1 or the BRCA2 genes. If her family had a different set of cancers, we might have considered analysis of different genes. Based upon this history, we talked with Jeannie about the features of the BRCA1 and BRCA2 cancer syndromes. And Jeannie decides to proceed forward with genetic testing. And in fact, she is found to have a mutation in the BRCA1 gene. Genetic testing is informative. It has provided us with new information. So what have we learned? We now know that the basis for the cancer predisposition in this family is due to a very specific mutation in the BRCA1 gene. We know that families who have a BRCA1 gene mutation, for those women in the family, they have a high risk for breast and ovarian cancer in their lifetime. There's also an increased risk for prostate cancer among men and pancreatic cancer among any family member with the mutation. The risk for prostate cancer and pancreatic cancer are not as significant as the risk for breast and ovarian cancer. We also know that family members who have this mutation have a 50% chance to pass the mutation on to each child, and an equally likely 50% chance not to pass on this mutation. Jeannie can use this information to guide her medical care. We know she has an increased risk for second primary breast cancer based upon the presence of this mutation, as well as an increased risk for ovarian cancer. We also know by having identified the gene mutation in the family that we can offer other family members genetic testing. By knowing this mutation, we can distinguish who in the family has the mutation and is at increased risk, versus those in the family who do not have the mutation and are not at increased risk. Let's consider two different family members who pursue testing. Jeannie's paternal Aunt Sally is 74 years of age and she is healthy. She has no personal history of cancer. After Jeannie is tested, Sally decides to proceed forward with genetic testing of the specific family mutation that was identified in the BRCA1 gene. Her testing was negative. What does this tell us? We know that even though Sally's family has the BRCA1 cancer predisposition syndrome, she did not inherit the cause of that syndrome. She does not have an increased risk for breast and ovarian cancer. And importantly, she cannot pass on the mutation to her two children. In essence, a person cannot pass on what she does not have. So her children are not at risk either. This is very informative in guiding their medical care. Now let's consider a different family member. Jeannie's paternal first cousin, Michelle, decides to proceed forward with pre-symptomatic genetic testing. Michelle's sister was diagnosed with breast cancer at a young age. Michelle has not had any cancer diagnosis, but after meeting with a genetic counselor, she decides to proceed forward with testing and is found to have a mutation. What have we learned? We know that Michelle, based upon the presence of that mutation, has an increased and high risk for breast and ovarian cancer. And we can use this information to guide Michelle's care, whether it be intensified surveillance, or perhaps Michelle may consider prophylactic medical or surgical options. What we don't learn from genetic testing is some very practical information. Although Michelle has a high risk for breast and ovarian cancer, we don't know if she will ever be diagnosed with these cancer types. Genetic testing cannot tell you that. Furthermore, if a person is going to be diagnosed with breast or ovarian cancer, genetic testing cannot tell you when this diagnosis will occur. You can imagine that a woman who is going to be diagnosed at age 40 years of age may make different medical decisions than if that diagnosis will come at 75 years of age. Genetic testing cannot distinguish that for us. In this family, genetic testing was incredibly helpful and informative. We identified the cause of the hereditary cancer, and by knowing that information, we're able to distinguish who in the family is at an increased cancer risk and who is not. Now let's consider family two. Mary is a healthy 36-year-old woman who presents for genetic counseling based upon her family cancer history. Again, we have a striking paternal family cancer history, and in this case, this family has multiple family members with diffuse gastric cancer. Gastric cancer is a type of stomach cancer, as well as lobular breast cancer. Again, we see that this family has hereditary cancer by the presence of multiple family members who are affected, multiple generations, as well as early age at diagnosis. Again, this family has hereditary cancer. And by these two features in the family, we know that they have a very specific cancer syndrome diagnosis. We refer to that as the hereditary diffuse gastric cancer syndrome. Remember that syndrome simply means things that go together. And in the case of cancer predisposition, cancer risk that are due to the same gene mutation. In this particular syndrome, the two predominant features are diffuse gastric cancer and lobular breast cancer. And in about a third of all families with this particular syndrome, they have a mutation in a gene called the CDH1 gene. We also refer to that as the E-cadherin gene. Mary has done her homework. She's documented her family history, and she's also read a little bit on the internet about this particular syndrome. And she seeks genetic testing of the CDH1 gene. As we proceed forward with her genetic counseling, we get back to the very basic rule of genetic testing, and that is to start with an affected family member first. So we actually recommend to Mary that she speak with her paternal first cousin, Catherine, who's been diagnosed with gastric cancer at 29 years of age. And we recommend that Catherine proceed forward with genetic testing. Catherine agrees, and she has genetic testing of the CDH1 gene. And her testing is negative. There's no mutation identified in this gene on Catherine's testing. What does that tell us? We still know this family has hereditary cancer, and what we've learned by the testing is that it's not due to a mutation in the CDH1 gene. For the vast majority of families with this particular cancer syndrome, and quite honestly, with most families with hereditary cancer, we do not figure out at the gene level what has caused that history. That's simply a limitation of the science. We need to make further discoveries in the genes that are associated with cancer. Given the fact that Catherine's testing is negative, we do not have an informative test, an informative genetic test, to offer other family members to determine if they have an increased cancer risk. So we cannot pursue genetic testing for Mary. We do not know what to look for because we do not know what has caused the cancer predisposition in this family. Since we don't have an informative genetic test, we have to assume that Mary and her brother Chris, as well as all of her paternal relatives, are at high risk. We have to presume and assume that they are at high risk until we have an informative genetic test. This will guide our screening. We will recommend additional screening for them based upon their family history. Now let's talk about a common mistake that's made with genetic testing. And this is a very crucial piece of information. Let's go back to family 2. And Mary comes in for genetic testing. And let's say we don't offer Catherine genetic testing, and Mary pursues testing first. Mary is unaffected, and she has genetic testing of the CDH1 gene, and that's negative. We've made a mistake by offering Mary testing first. She has immediately assumed that because her testing is negative, that she's not at high risk. This is not a correct interpretation. Since we don't know the underlying genetic basis for the cancer in this family, we cannot assume that Mary's negative testing is a true negative. And in fact, this testing would be considered non-informative. This is a challenge for many people and even health providers to understand. We're so used to thinking about medical tests when they're negative as good news. But we don't think about genetic testing as good or bad. We think about genetic testing as, have we gained new information? And in this case, by starting testing with Mary first, we have not gained new information. Her testing is negative, but we still don't know at the gene level what has caused this family's cancer history. Mary would still be assumed to be at high risk. It's a common mistake for many people to proceed forward with genetic testing without having tested an affected family member first. In these scenarios, we have to be incredibly cautious in how we interpret a negative test result. If you have questions about this scenario, or if you've pursued testing without having an affected family member tested first, speak to a genetic counselor about your test results. A list of genetic counselors in your area of the country is available through the National Society of Genetic Counselors. Now let me just say a few comments about genetic testing and where genetic testing is headed. We've been performing genetic testing for several decades. Initially, that testing started with chromosome analysis. Chromosomes are the structures that package all of our genetic material. And several decades ago, we could essentially count the number of chromosomes and determine if part of a chromosome, a very large part of a chromosome, was missing. If part is missing, certainly the genes on that piece of the chromosome are also missing. As technology improved, we were able to proceed forward with analysis of single genes, and then that led to the development of being able to test 3 or 4 genes at a time. And now for people with cancer, we often use what we refer to as gene panels, where as many as 20 to 40 genes can be analyzed at one time. We have to remember that's a very small part of our entire genetic makeup, and that individuals have over 20,000 genes in every cell of their body. In the future, and what's being performed on a research basis right now, is the evaluation of what we call exome sequencing, where small pieces of thousands upon thousands of genes are being evaluated. And on a research basis, and eventually will come to the clinic, is whole genome sequencing. Whereas sequencing technology improves, and importantly, the analytical tools to evaluate the genome improve, we'll be able to not only look at a handful of genes, but actually sequence a person's entire genetic makeup. This will provide new answers for families where we couldn't identify a gene mutation in the past. But it will also raise important questions. Perhaps you're coming in for a diagnosis of cancer, and we provide you with different information related to your health, or the health of your children. I encourage you to keep an eye on the news, ask your medical team, speak with a genetic counselor, or check back at this video series to see how closer we are to incorporating whole genome sequencing in the clinic and in the care of people with cancer. Thanks so much for watching.